Coming up today, she thought she was perfectly healthy. Then she got a simple scan that revealed a potentially deadly problem brewing inside her. Good morning, I'm Alexis Del Cid. Welcome back to All Things Heart. You may feel healthy, exercise regularly, keep up a healthy diet, yet you still may have a serious problem in your heart. Today we're talking about a quick and easy scan that can detect potential heart problems. It's called a coronary calcium score, or commonly known as a CardioScore. Here's someone going through the test right now. A CardioScore gives doctors and nurses a look inside your arteries to see if there's plaque buildup. And for Cathy Jacobson, it saved her life. We are so happy to have Cathy in the studio with us today, doing great. And she is alongside her cardio-thoracic surgeon, Dr. Greg Muehlebach. Thank you for being here. And of course, sitting next to her is her cardiologist, Dr. Jean-Alfred Thomas. Dr. Thomas, thank you. Dr. Muehlebach, you performed a quadruple bypass on Cathy. Cathy, how are you feeling today? It was in March.
Yes. I'm feeling great. Everybody tells me that I'm doing fine. I haven't had any problems. I'm doing cardiac rehab 3 days a week, and I feel great.
Feeling good. How soon after your CardioScore did you find yourself in the operating room with Dr. Muehlebach doing the bypass?
I'd say it was about a month, maybe. I did a number of different tests along the way, and I failed every one of them. So they just kept adding on more tests until I went in to have a stent. And the doctor was in about 10 minutes, you're awake when you do a stent. And he came around to my head and he goes, "I'm done. And I'm not doing anything." He goes, "You need a bypass." So I was completely surprised.
So what was it, you thought you were doing fine, and you thought your only problem was cholesterol, right? So how did you wind up getting the CardioScore?
My primary doctor referred me to Dr. Alexander, who's a lipidologist here that specializes in cholesterol. I have a family history of cholesterol, and nothing that I took or did would reduce the numbers. So he recommended doing the CardioScore.
Okay. And the CardioScore is one of those things, Dr. Thomas, where you're the lowest, you want to score low.
Correct.
It's one test you want to score.
It's the one test you want to zero on, exactly.
What did you see on Cathy's test that made you go, uh-oh?
So certainly the quantification of her calcium was high. It was about 400 plus, and so that would put her in kind of an elevated or high risk of individuals.
Okay.
So that number in itself does raise concern about what burden of disease is there or not there.
And we have I think we have an image showing the different levels of the ranges you can score. So, she was 400. That's
400
high.
plus. I think she was actually like 423 or 426. Wow. So there was a significant amount of plaque there. And really, that just speaks to the presence of disease. The big nuance to her case is usually these calcium scores are in asymptomatic patients, folks without symptoms. As we discussed beforehand, she had a little bit different picture where she had some nuance to her profile that said, hey, there's something hiding underneath that elevated calcium score.
So by the time Cathy reaches you, Dr. Muehlebach, how many tests has she had that led her to your operating room?
Probably a lot, but the biggest test is just her cardiac catheterization. So,
okay.
As she said, when they look at the pictures and they say you're not a candidate for a stent, we're going to have to do bypass surgery, then that's when I get involved.
So did you know it was going to be a quadruple bypass going in? How do you...
Actually, it was 5, I believe.
A quintuple bypass?
Yeah.
What's the most you've ever done?
I don't know.
But 5 is a lot. 8? Did you say 8?
Yeah. But, you know, the number really is different.
Yeah.
I mean, 5 doesn't mean good or bad.
Oh.
It's just what she has. Everybody's anatomy is different. But when when we go in, we've looked at the pictures, and then we decide, or we try to make a decision, how many bypasses do we need to do, and so that we can decide how much vein we need to take from her leg, and, you know, what we're going to do to perform the surgery.
I always thought that the more bypasses was the most serious, because when you talk to non-medical people and say, he had a quadruple bypass or she had a quintuple, everyone goes, when they hear single, double, I thought it was worse the more you got, but it's not?
It depends. I mean, sometimes you only do one because everything else is so bad you can't do it. So that's not necessarily a good thing. If you only need one and the others are okay, that's great. But no, the number doesn't really portend a prognosis.
When did you have an angiogram? You had a CardioScore, and then what was the next test you had?
I had a Doppler echo. You probably know better than me.
We pursued an echocardiogram, but chiefly what she underwent was a functional stress test. We were trying to lend character to her symptoms as well as that calcium score. The calcium score, again, is this it's a small univariate. It's a very blunt instrument, but again, we wanted to nuance that number. So she got a stress test to understand if there's a flow-limiting lesion of significance.
You said you wanted to add character
to that number. Just because, again, that number in the ethos by itself just tells you what to do about a person's risk of disease, but the stress test tells you whether or not there's actual notable disease that we need to act upon more urgently.
Okay.
Yeah.
And then, Cathy, you had your quintuple bypass. How long was your recovery? What did that look like?
Well, I guess I'm still considered in recovery.
Sure.
I believe they consider 12 months to be, when you're fully recovered. I'm doing great. I was in the hospital for about 9 days, and then at 2 months, I think I started cardiac rehab.
Okay. When you came in here, the first thing you said to Dr. Muehlebach was, she said, I was hoping I'd never see you again.
I didn't mean it really.
You said it with a smile. What's the last thing you remember about seeing Dr. Muehlebach here as a patient?
Oh, just that he's funny and kind and did a good job.
What did that conversation look like when you were explaining to Cathy what you were going to have to do?
Well, I think the biggest thing is you're seeing somebody who, like she was, thinking she's getting a stent.
Right.
And now
I was probably oblivious to the whole thing.
How long after the stent that didn't happen did you find yourself meeting Dr. Muehlebach then?
I think we would have done it within a day or two, but we waited a week.
Okay. So what was that?
You want to tell him why?
Yeah.
I don't remember why.
Tell us why.
Because he went to spring training and I wanted him, so I waited.
You waited. We've heard that from other patients. You're a hot commodity. She wanted you. You're
Well, I appreciate that.
I made you blush.
Well, I just have to pay
Dr. Muehlebach blush.
Pay
Thank
people
you.
like JT to just say those things. So
you do?
I do for free,
you paid
though.
Cathy?
yeah.
Oh, I say the good things about Dr. Muehlebach for free.
That's a good response.
Yes.
So you come back from spring break. You have this patient, Cathy, that's waiting for you. Did you know she was waiting for you after your spring break?
Well, no, I knew about her test results and had seen them. Yes.
Okay. So what was that like when you actually got the news that I'm going to have this major surgery? How did you process that?
I'm not sure I did for a couple of days because I just didn't expect that anything was wrong with my heart at all. And even right before we went in to do the stent, Dr. Gupta did it, and he's like, I don't think this is going to solve your problem of being short of breath. And I said, well, we'll see. And then he did a complete turnaround and said, you're getting a bypass.
Wow. How long had you been short of breath?
I'm not really sure, maybe 2 years. I mean, I thought, well, I'm overweight, I'm getting older, maybe this is just how it is.
Right.
And it wasn't debilitating, I just had noticed it's a little harder for me to take a long walk, or, I get tired sooner.
We hear this from a lot of women, I feel like, patients we have on the show where they feel these symptoms and then they write them off. How common is that for you to have a patient who's a woman versus a man who's just kind of written off their symptoms for a while?
I think traditionally you're looking for that story of typical angina. You're looking for the chest pressure, the chest discomfort with exertion. I think that rings more alarm bells. But certainly when you have folks of certain risk profiles, you think about the atypical. So one part, to give yourself some grace, she, fall of 25, there was some shortness of breath. It changed on her. As we kind of talked, it sounded more of the pulmonary stuff you suffered. It was a little meaner. It was a little bit more progressive. It seemed like it was easier for her to get short of breath. And it was the dynamicness of that symptom was kind of concerning. But sometimes you do find folks with atypical symptoms, and the risk profile, put that together, will drive whether or not there needs to be further investigation. So not every patient has atypical, but you do have to think about it can be common to have these conversations with folks and find out, oh, it's not the chest pressure story. It's shortness of breath when you exert yourself, and it's easier to get short of breath.
And then how often is it, Dr. Muehlebach, that you'll find yourself about to operate on a patient and this whole problem was discovered because of a CardioScore, such a simple scan? I got one and it was the easiest test. It takes about 5 minutes. Is this a common thing that is like a common reason why a big problem is discovered?
It's very common, and it's not just heart bypass surgery that we see that CardioScores tell us. So some people have an aortic aneurysm, or they could have a lung nodule, or there's lots of other things that the CardioScore will pick up that not for the purpose of the CardioScore, but just happens to see. So it's very common that you hear somebody say, "Oh, I got this for my 60th birthday from my wife, and here I am."
Oh, they said it was a birthday present?
Yeah.
So it is very common to find people that get them that have zero expectation that they're going to end up in an operating room, but
Sure.
here they are.
That was certainly my case. I had one when maybe 15 or 20 years ago. My score was 0. I didn't know that it continues to climb as you get older,
Okay.
And had no idea that mine could have been this bad.
Had you heard of a CardioScore before you got that first one? Did you know what they were?
One of my women's groups had a nurse that worked in cardio at St. Luke's, and she came and gave a talk to us, same kind of thing, promoting getting the cardio score. That was the first time I had ever heard of it.
I was surprised at how easy it was to get in and schedule an appointment here. It was the simplest thing. There's a number you call, and Kay Ness, who's wonderful, she's the RN, and she read my results, got them within 5 minutes, and our boss here, Jill, got a CardioScore. We have video of her as well that we might play throughout the program. Such a valuable exam and life-saving for you. We do have some questions and some comments coming in from our viewers, so I want to give the people watching a chance to get your comments and your questions, and if you have anything that you want us to read out loud in the program, you can send it to us right now on YouTube, Facebook, or the All Things Heart email, and those links on how you can connect with us in real time are right there on your screen. Cathy, were you in a lot of pain when you woke up from your surgery?
Surprisingly, no. I really didn't have much pain at all from the heart surgery itself. I had a lot of back pain. I guess it's the way they splay you out on the table for the surgery. I don't know. Really, the back pain was the biggest part of it.
And why is that? Because you just have to get the patients in the right position to reach things, right?
Well, some of it's the opening the chest, and some of it's laying in the beds. They're kind of stuck in one position for a long time. But her comments are very common, especially amongst women. The men are wimps. But it is interesting that when you do bypass surgery, when you open the chest, you don't cut through any muscle. The bone is below the skin, and once the bone's secured back together, most people their pain is very relatively easy to manage.
Okay.
Versus some other incisions.
They basically send you home with Tylenol. The pain's not that bad at all.
That's incredible. And it's such a major surgery. We're also showing video throughout this program, and you're in a lot of those shots, all masked up, performing your open heart surgery. Thank you for letting us in your OR for various things. It's fascinating to see. Dr. Thomas, Cathy had an elevated LPA and a family history of heart problems. So for people watching, how much does an elevated LPA factor into ultimately having a huge problem?
Great question. So certainly, you're looking for the traditional risk factors, but the elevated lipoprotein A, which has kind of gained more steam, and certainly has got some note in the recent guidelines in 2026 for lipids. As a molecule, it does carry a pretty kind of nasty profile. Some people say, or I may say specifically, it's kind of having your traditional LDL, your bad cholesterol, a little spicier than the usual. So looking at a molecule that's a little bit more inflammatory, a little bit more plaque developing, and a little bit more thrombotic. So more plaque, more irritated plaque, more propensity to clot off or create stenosis. And so look at it as more of a additive or multiplicative effect on your traditional risk factors. So something that kind of raises the suspicion even further when you think of folks, hey, there may be something lying in wait because of this factor.
And you also have a family history of heart problems?
And as far as I could tell, the LPA being elevated, it also indicates why statins wouldn't work for me, because it's hereditary.
And before the program began, Dr. Thomas, you were talking about that being the reason why Cathy was seeing a lipidologist.
Yes.
So what kinds of medicines had you tried to lead you to think?
Every one of them.
To lower your cholesterol.
Yes.
Yeah. And it was resistant.
I had oh, how do I want to say it? Most of them gave me really bad back pain.
Statin intolerance.
Why would it cause back pain?
Sometimes with statins, which again are traditionally very safe and well tolerated, there are subsets of folks who have muscular intolerances. They can kind of call them like muscle cramps and big girdle muscles and so forth. It is probably, if you look in the Dr. Google kind of sphere, a little bit more common than it really is. It's really, if you look at some literature, it's like 5 to 15% of people have some statin-related issue in terms of myopathy. But there are folks who legitimately just can't take them. Thankfully enough, there's been evolution of interventions and agents specifically that do allow us to kind of bypass the statins. And in her instance, because of her risk profile and family history, Dr. Ethan Alexander was very aggressive about getting her into an appropriate range of like lipid control. And so, thankfully enough, again, you've got guys like Ethan and Alexander who are very progressive, very thoughtful about that space. And so there's been definitely a push to get that lipids profile normal.
So you had shortness of breath, and that's what you'd been talking about. Looking back, Cathy, is there anything else you can think of that might have been a symptom that you didn't recognize as a symptom?
I don't think so. I didn't have any heart system symptoms at all.
Wow. So Dr. Muehlebach, I'm always curious about this. You're the final stop on this journey. When you wind up in the OR, it's because something drastic needs to happen. When you opened up Cathy's chest, what did it look like to you? Is there a way you can explain it in non-medical terms, what you see that leads you to think, okay, this is a problem, this is why we need 5 different bypasses?
Well, the angiogram is really the biggest kind of predictor, if you will, of what somebody's risk factor is moving forward if you do nothing. So how bad's the blockage, where is the blockage, and whatnot. You know, when we get in there, we can't see that. We just see the surface of the heart. But we can sometimes see that in some patients that the blood vessels will have plaque just at the very start of them, or in areas where they're splitting. And then the rest of the arteries clean, looks fine. And then there's some patients that the plaque is throughout the entire artery, and those patients have a worse prognosis because they're prone to get more disease as time progresses. So doing bypass surgery doesn't arrest her disease. Right. Just as it says, we've bypassed the blockages. So her disease process of atherosclerosis continues. But in her case, those arteries beyond those blockages were clean, look good. So I think that, in that sense, the prognosis is very good. People that have diffuse disease, as we would say, their prognosis is maybe not as good, and we would say be much more aggressive about your statin therapies or cholesterol therapies, whatnot.
When you say diffuse disease, what does that mean to someone who doesn't have a medical background?
So the whole artery has disease instead of just the start. So typically we see it towards the start of the artery, not throughout the entire artery.
So after seeing Cathy's journey, as doctors, would you recommend younger family members of Cathy's get CardioScores? Well,
I mean that she already had a family history. Yeah. She continues to carry on
the family history.
Yep. Yeah. My son also has elevated LPA. One of them has his tested. Yeah. We haven't tested the other one.
So would you recommend that her sons get CardioScores?
So there is some literature for, traditionally people get CardioScores recommended around the age of 40.
Mine are not quite that old.
Not quite that old. Usually it would not be unreasonable to say at the age of 35. Right, hey, maybe get a little earlier to see. There is some literature about testing quote-unquote younger folks to see. The only caveat to that is that usually, the calcific plaque changes usually start to show up around 40. So you may get a calcium score of 35, not calcify yet, and have a false sense of reassurance. Oh, it's 0.
Yeah, that's what I had.
Right, and especially we do think a little bit in the lipoprotein A population, there may not be this propensity to form the nasty hard plaque earlier. But again, her sons would be someone we would watch earlier than most, just because, again, mom's had it, family history, tradition, so forth. Shouldn't call it tradition, but family history, that is. So probably a little earlier screening protocol.
Okay. Yeah. So Dr. Muehlebach, when you have a patient on your table in the OR, do you always know what the first test was that brought them here? Like we know for Cathy, it was a CardioScore. Because there have been so many tests leading up to this point, would you be able to know off the top of your head how common it is to be performing open heart surgery on someone who the problem was discovered in because of a CardioScore?
I don't know what the number is, but it's becoming much more common. You would be a pioneer to have done it 15 years ago.
CardioScore?
Yeah, there were not many and they cost a lot more money back then. And
yeah, and I had to pay out of pocket.
Part of that discussion is, this is an
Really?
out-of-pocket expense for everybody. This is never paid for by insurance. But back in the day, it was probably well over $300, and today it's $49.
Yeah, I think it was under 50.
Yeah.
One
So, so with that change, there's many more people that are getting cardio scores that then lead to seeing somebody like me.
That's incredible. So 15, you were a pioneer.
I did not know that.
But thank you for being on this program, because still a lot of people don't know about cardio scores. I didn't know what a cardio score was till I started working here, and the doctors were always talking about them. And there's that scan. Cathy, can you share a little bit more about the experience of getting a cardio score?
It was very simple. It's not invasive at all, and you kind of just roll into the donut and you're there for a couple minutes and roll back out again. It's not any big deal.
It's not long. It's not like you're in a tube for a long time if you get squeamish in tight spaces. It was very quick.
Very quick.
And convenient. I want to get to, first I do have a question for Cathy. Has this experience changed the way, and how has it, that you think about preventative care and preventative scans?
Well, I didn't know that I needed preventative care. That was part of it.
Sure.
And also now I'm also aware that I still need this care. I thought if you had your bypass, you were pretty much done. And it turns out that your bypass can also get clogged with particles, and you can't just say, okay, I'm fine now. I'm not. I've still got to follow my cholesterol, and they're talking about different ways for me to do something about that.
I want to get to some of the community questions, because we have one coming in from Jeremy Yenser. Jeremy writes, Cathy mentioned getting a low score years ago. It was 0, right? And it was 400 then, the second time you got one. That it can get worse over time is interesting. So how frequently should we be getting cardio scores? It's an interesting question.
So I'll field that one. So traditionally, let's say assume from the start we start with 0. And traditionally speaking, starting with the population of 0, depending on your risk profile. So, and when you go into your doctor and you talk about risk of heart disease, we're talking about risk stratification and putting you in pools of risk. Traditionally speaking, if you're starting off with 0 and you're in a lower risk pool, so you have event rates of, let's say, less than 5%, we're looking at, hey, get a score every 5 to 7 years. If you're kind of a borderline intermediate risk individual, we say every 3 to 5. If you're a high risk individual, we'd say, hey, every 3 years. And high risk is inclusive of folks who may have, again, burdensome risk factors, strong family history, even diabetics, with the notion that you're trying to see if you can develop a trend for what their atherosclerotic progression will be. So that's usually the frequency of it. Usually I don't see much in the way of needing to get that yearly. The change from year to year would be relatively negligible. It wouldn't change our practice patterns, it wouldn't change our management. But the intervals of testing that I kind of mentioned would be the way to look at that sequentially.
Jill wants to know, how long is a quintuple bypass surgery? How many hours is that? How many hours?
3 to 4 hours usually.
How many was Cathy's typical? And is it, how many people are involved? The second question, how many people are involved in the surgery?
A lot.
Yeah, there are a lot. Well, there's an anesthesiologist, and they typically have somebody with them, and then there's a perfusionist that runs the bypass machine. There's a nurse scrubbed that hands me instruments. There's a physician assistant that harvests the vein and then assists with surgery. There's a nurse in the operating room called a circulator that isn't scrubbed in that can grab things for us if we need them, and then anybody else. So that's something that I think is interesting when we have students that want to come shadow and see what I do, and I'm like, what? There's a lot of other things that are done here too. So there are a lot of professionals in the room that are assisting in the procedure.
I've had other surgeries, and usually I'm knocked out before you ever see the operating room. This was the first time I've ever been in the operating room and saw all the people rushing around to do. I was like, did you forget to give me drugs?
So what's the last thing you remember before going under?
Pretty much saying that. She's like, it's coming, it's coming.
Did you forget? And then it's like lights out?
Pretty much.
And then when would you just see Dr. Muehlebach's face over you? When you opened your eyes, when was the next time you saw Dr. Muehlebach then?
I don't think I know. I was out of it for a while, and they take you right back to your ICU room. I woke up when they were taking out the tubes.
Yeah. Most people get the breathing tube out within 6 hours, and even though they get the tube out, they still have some anesthesia on board. So there's many times that we talk to the patients then, and they don't remember talking to us for a good 24 hours.
Did Cathy say anything juicy?
No.
My husband claims I was begging them to take the tubes out. I don't remember anything about that.
Well, that's not that juicy. I mean, that sounds pretty human. Lou has a question. He wants to know, he or she, curious, does cholesterol come in different sizes? Little cholesterol that sticks together and large cholesterol that passes through? I've heard that before. Just curious. Are there different sizes of cholesterol?
So there are different particle sizes, and not to get too say nerdy with it, that does play a role. Usually those particle sizes can indicate their plaque forming properties. And so understanding even the word cholesterol, we've kind of taken a portion of what is really your lipid profile, which is probably the better term for it, and use cholesterol as a quicker way to communicate that particular part of the human system. But lipid particle size is important. It does dictate, again, plaque formation and risk of plaque development. And it's something we address when we look at your lipids to understand where you sit in risk and how to modulate your risk.
Did you want to add something to that?
No.
Because I do have a question for you, because Becca has a question, and it just sparks something you said about how it's becoming so much more common that big problems are discovered because of cardio-scores. So Becca wants to know, why are cardio-scores then not part of a yearly physical, just mandated? Care to espouse on that? Why, if it's so helpful?
Well, they're helpful, but they probably aren't very helpful in people under the age of 40 if they don't have risk factors.
Okay.
You're not a score of 0, but there is the risk of radiation exposure when you do. It's basically, it is a CT CAT scan of the chest. And so even though it is low dose, to do it every 5 years or 3 years is not significant. However, there is a risk of radiation exposure. So we can't just put everybody through screening every
year,
head to toe with a CAT scan. So, we do have to then take in, the risk and, where they fall in that regard. But
that makes sense. So, Cathy, as we wrap up this conversation, what would be your message for our viewers who might have never heard of a cardio-score till now and then hear your story?
I think that y'all can tell me the proper age to have your first one. It's probably 50.
I would say probably 40.
40. I think that they should be very aware that it's available, and there are some low-cost options to get the score. It's definitely important not to wait to have symptoms. I seem to have had a much better recovery than other people that I've talked to that had a heart attack or a stroke first. I think that helps recovery immensely. I was in pretty good health before this happened. So I would definitely keep track of that. I would keep track of your cholesterol numbers, get an LPA test, and see if you have a family history of high cholesterol. I
do have one more follow-up question. Based on what you've seen as doctors, how long could Cathy have gone on with this had she never gotten a cardio score? What would have happened within 5 years?
Again, it's always going to be it's hard to say. Certainly, with that burn disease, again, there's evolution, right? And despite best efforts to check it, unfortunately, if it progresses enough, you're talking about, closure down of vasculature. That could lead to, in some instances, silent MIs, myocardial infarctions, or heart attacks. And then, as she mentioned, you've then suffered an injury to your heart, and it's put you in a different category altogether, where her robustness now is thankfully enough because she's dodged those insults.
Right.
But it could, and again, no one's got a crystal ball, but it could have more deleterious effects if that disease progresses without being checked.
Like, based on what you saw when you operated on her, was this like a ticking time bomb?
You really don't know, because you can have a 50% blockage that it could occlude in an hour from now.
Wow.
So the degree of blockage does not predict the stability of the blood vessel as far as whether or not you'd have a heart attack or not. So unfortunately, there are patients that we see, they get a heart cath, we schedule them for surgery and find out, that they had a heart attack 2 or 3 days later before they got to the operating room. So, but having said that, not everybody's rushed off to surgery.
Sure.
And so we do have to strategize when they go. But there are some that get a heart cath and we go straight to surgery, and then there's others like Cathy that we can say, your surgery needs to be scheduled. You go home and and then we'll bring you back. So we can't predict those things, but on the other hand, we have to be a little more common sense and level-headed about when
Sure.
they should go, but the patients also have to be realistic too, that they've had the procedure, they know they have heart artery disease. They don't go home and mow the yard and shovel snow. Or
Yeah, I
do
would
something.
add that it's pretty scary to go home and think, well, there's something wrong, but
Sure.
what day is it going to happen?
Right.
I was afraid to walk very far from home, and you just want to watch yourself in between.
Sure. Dr. Thomas, what kind of patient is Cathy?
Awesome. She's a good patient. I think, but we've already seen evidence of that in the fact that, this goes back to when she was engaged with Dr. Alexander, right? She's being preventative. She was trying to prevent events, and she has, thankfully enough, notably. So I think she's been good because she's wanted to take care of herself, and she's leaned into that. And I think that's the first part. It's, where people have the improvement in their mortality and morbidity. So, yeah.
Dr. Muehlebach, what do you want our viewers to know and Cathy to know moving forward?
Well, I think one thing that JT was touching on, but the lipid clinic here is literally world renowned.
It's incredible.
And the physicians in that group are some of the leaders in the world on treatment of these processes. And so I think that that is something that does not get enough attention here because they're not in the operating room. They don't have these big glamorous life-saving procedures that people want to hear about or see about. But on the other hand, treating somebody with lipoprotein small a like she has, there is no treatment right now. And so these are the people that are on the cutting edge of figuring out what that treatment is and how do we do it. So I would give kudos to that clinic, number one. I think that that is something that is unique here, not just at KU, in the region.
Right.
They are very unique.
In the world. Dr. Patrick Moriarty has been on this program before talking about the different treatments in lipoprotein apheresis, which we can get into on more programs, but it's remarkable what you all do.
That's pretty much what my next step is.
Lipoprotein
And the
apheresis.
clinic is the largest in North America, I think, right?
Very successful, yeah.
Yeah. Well, you know what? We'd love to have you back on. Follow you on that journey. We'll get a threefer because it's your second time on. Thank you so much for being here, Cathy.
Sure.
And Dr. Thomas, Dr. Muehlebach, thank you both for taking the time out of your days to join us. And thank you to our viewers for joining the conversation. Coming up tomorrow morning, we have an incredible update to a journey so many of us have been following. We're talking about Bree Bauer, who has now received a life-saving birthday gift from her brother. It's a kidney. How that transplant is helping Bree build back her strength, her independence, and her life tomorrow at 8 a.m.